So, welcome you all to the webinar. And this is the first time I'm handling a webinar. So, yes, thank you so much for joining. And let me introduce our speakers for today. Dr. Sandesh Panta, he's a alumni from BRAC University, Bangladesh. And now he's our chairman for the IR Connect Steering Committee. And he's a PhD student and also a part-time professor at Latrobe University, Melbourne. Anything to add, Dr. Sandesh, to this?
Nothing. That was a good introduction, but I'm not a professor. I'm just a tutor lecturer.
Okay, then. And we have again Dendup from Bhutan. He's also BRAC alumni, and he's a program manager for the National TB Control Program, Department of Public Health, Ministry of Health in Bhutan. Also, currently he's serving as a member of the Southern COVID Task Force.
Thank you for the introduction.
So welcome Sandesh and again for the webinar. Now I'm handing over to Sandesh. You can start your session.
Thank you, Nidhi, and thank you for joining us in today's session. So basically, this session, we are organizing these sessions to develop partnership between TDR alumni as well as TDR scholarship holders so that we can work together in developing partnership for research across different universities in the world. So a brief introduction about TDR would be not possible within few minutes, but briefly telling that TDR scholarship is being offered throughout 7 campuses in 5 different continents, and many people have already graduated with this scholarship. And that is why, as we have a increasing number of alumni, so we are trying to work to develop partnership among us so that we can give some output to the research world, which can be beneficial in planning and implementation of communicable diseases. So that is why we want to share our experiences, share our past research among ourselves, and plan to work developing some partnerships so that we can do some research work in collaboration with each other. So thank you for joining us today. So today we shall be, Ugen and myself will be discussing about our research project while we were MPS students in Bangladesh. So I'd like to share the screen to. Okay, so I think we are now able to view my screen. So we shall be discussing today about our research program, which conducted in 2017. So our topic was facilitators and barriers to implementation of current childhood tuberculosis management strategies in BRAC-supported TB program in Bangladesh. So it was a mixed method study. So a part of implementation research under the MPS scholarship provided by the WHO-TDR committee. So basically, the reason why we selected childhood tuberculosis was because that the World Health Organization estimates that childhood tuberculosis should contribute about 10 to 15% of tuberculosis cases in high burden countries. However, the number of cases reported in these countries is very less than 5%. So that means that the actual detected case numbers is around 33% of what actual numbers could be. And it is globally of the estimated 10.4 million new cases of tuberculosis, 1 million were children below 15 age. So it's a high burden. And if we see the prevalence of tuberculosis cannot be controlled unless and until tuberculosis in children is identified and treated in the community. So that is why we were more focused in childhood tuberculosis research rather than going for other research program during our thesis, right? So that is why we selected the topic of childhood tuberculosis, and we wanted to explore, identify the bottlenecks in the implementation strategies to improve childhood TB diagnosis, treatment, and prevention in Bangladesh. So that is why we choose this topic. And in this topic, we had 5 different components. We took 5 different components, 5 different objectives for 5 of us. So one was the trends study, so in which we had reviewed the trends in identification of childhood tuberculosis in Bangladesh. And the second, which was my component, was facilitators and barriers in diagnosis and treatment. And Dendu Bhai, his component was facilitators and barriers in human resource management for childhood tuberculosis. Similarly, we had 2 other colleagues who looked after the Isoniazid prevention therapy, as well as supply chain management in childhood tuberculosis. So we had these 5 different objectives, and our overall collaborative project was childhood tuberculosis. So our study design was concurrent triangulation design, which is a type of mixed methods study where we collect qualitative data separately, we collect quantitative data separately, and we combine and mix, we analyze this data and produce the result, synthesize the result. So yes, Abibi, I have not that slide on the 5 different objectives. So that is why I am mentioning it verbally. So we had 5 objectives taken by 5 colleagues, and these 5 objectives were addressed by a mixed method design collaboratively. So we took the data collection, we had the data collection, we had the collaborative data collection, all the 5 which included all the 5 components, and then we analyzed it separately according to the objective. So our study site included 8 urban dot centers in Dhaka city. So basically, these the Dhaka City Corporation had 24 dot centers, and among those 24 dot centers, we selected 8 of them. How we selected was we identified the centers. Nidhi, can we mute all the persons who are not speaking? We can hear some background noise. So how we selected was we identified the incidence of childhood tuberculosis in these 24 dot centers for the 18 months period, right? From January 1, 2016 to July 2017. So over this 18 months of period, we identified the individual new cases in each of these dot center. And then we selected the 4 dot centers with the highest number of cases identified, and 4 dot centers with the lowest case identifications. So we choose these 8 centers because we wanted to see if any factors were contributing to these differences in case identification. Nidhi, can you please mute? Okay, can mute. Okay, so basically we selected these 8 centers based on their case notification because we wanted to identify if any field level factors were contributing to those case notification. So our study period included 3 months, among which 1 month was data collection period and the rest were planning and analysis of the data. So our study, we had a mixed method study. So we included quantitative component as well as qualitative component. For the quantitative component, we had the Swasthya Sevikas, who are the frontline healthcare workers in Bangladesh. So these Swasthya Sevikas we will briefly discuss about their role later on. And then for the qualitative components, we had people from field level as well as people from the planning and implementation level. So the field level officers included the area managers, program managers in those BRAC dot centers, whereas we had senior managers from BRAC TV program as well as from the National Tuberculosis Program. As in addition to those, we had partners from the World Health Organization country office in Bangladesh, as well as Damien Foundation, which is another big implementing partner of tuberculosis in Bangladesh. Similarly, in addition to those field level officers, field level program implementers, as well as the senior level program implementers, we had some stakeholders from the recipient sites. So we had interviewed 4 childhood TB cases, mothers of 4 childhood TB patients. So to understand their perspectives as well. Let's see the results from the trends analysis. So here we can see the linear graph from 2007 to 2016, which shows the overall tuberculosis patients in Bangladesh. So if we see the trend, there is a gradual increase in the number of TB cases over the past decade. But if we see the trend in increase, so when we see the time frame between before 2012 and after 2012, we can see a gradual increase in the number of cases, number of adult TB cases after 2012. This was primarily attributed to introduction of Gene Expert, which is one of the easiest and most reliable diagnosis for tuberculosis. So after the introduction of Gene Expert, there was a gradual rise in the number of adult TB cases. However, the number of TB cases in children was not that pronounced as compared to adult cases. So there was an increase, there was a steady increase, but probably that increase was related to the overall increase in the number of tuberculosis cases rather than the effect of implementation of any program on childhood tuberculosis. So this is another graph by division, which shows the number of new TB case, child TB cases notification over the decade between 2007 and 2016. However, this graph, there is a overall increase in the childhood tuberculosis in all the divisions, divisions of Bangladesh. If we see the map of Bangladesh, Bangladesh is divided into 6 academic divisions. Bangladesh has 64 districts, but it has 6 academic divisions, so 6 political divisions. So if we see the division-wise trend, the trend was highest in the division which has the capital city compared to other divisions which are far away from the capital. So this can reflect that in the most of the services around tuberculosis management, tuberculosis diagnosis, control program was mostly focused in the capital territory. So similarly, this is also the trends graph according to the diagnosis of tuberculosis, whether it is pulmonary confirmed, pulmonary projected, pulmonary confirmed, or extrapulmonary. So this is case notification by different form. We can see that there is a gradual increase in all the forms of tuberculosis over the past few years after the Gene Expert was introduced in Bangladesh. Okay, so this is another graph which shows the tuberculosis incidence among the children in different age group, right? So the one in the left, this graph, it is the overall incidence of tuberculosis in children below 14 years. But when we break down this value according to age 0 to 4 years and 5 to 14 years, we can see that the majority of these cases are between 5 to 14 years of age. And there is hardly any change in the number of tuberculosis cases in between 0 to 4 years. And the interesting factor was that when I was writing the manuscript recently, I went back into the trends after 2016, after 2017, and I found that even in 2020, the prevalence of childhood tuberculosis in Bangladesh was less than 5%, right? Even after 3 years of our research, still the number of childhood tuberculosis cases in Bangladesh is below 5%, which has not significantly increased as estimated by the World Health Organization, which predicts that almost 10 to 15% of overall tuberculosis patients should be children. But still in Bangladesh, it is less than 5% in 2020, 2021. So we need to do a lot of work in improving in diagnosis and management of childhood tuberculosis. What are the bottlenecks in implementation of childhood tuberculosis? So let's divide these sections according to different components. So we shall be discussing to some extent about diagnosis and treatment, as well as human resource, and we will briefly touch on the Isoniazid prevention therapy, as well as the supply chain management. We communicated with our other colleagues to be present for today's workshop, but due to work commitments, 3 of our colleagues are not able to join this session today. So we are briefly discussing about all the individual components, but not touching in details about all these individual components, because it may not be possible in 1 hour. So 5 research presentation in 1 hour may not be possible. That is why we are trying to concise all the topics, all the findings to be shared with 2 of us. Okay. So let me go back to your question. So 2000 increase in cases starting from 2011 or 12 in the linear graph. So basically, it's like there is a slight increase in the number of cases from 2010, 2011. However, the gradual increase has been seen after 2013, when gene expert was implemented. But still, while we conducted this research, there were only 30 gene expert machines in Bangladesh, so which is not that sufficient number. So there was a lot of challenges still in there. So we shall be discussing those challenges in the coming slides. So what we looked was, even though the government has intensive implementation strategy for the tuberculosis control program, still the number of cases, although it's being an increasing trends, but the trends was not that significantly rising or significantly changing, right? So if we see the change in the number of cases in childhood tuberculosis, basically there was the number of cases between 0 to 4 years, it was negligible. 11 cases in a year. That's not a good number, right? So there may be a lot of hidden cases in the community which are not identified. But why? What is the reason why we are not identifying the adequate number of cases? What are the challenges in implementation of how can we improve diagnosis? How can we improve treatment in children? That is a major exploration from our research. So let's see the pathway of diagnosis, how tuberculosis program is implemented in Bangladesh. So basically, it's a community level program. The program has been implemented in the community. So where the suspected cases are identified in the community by the program organizers, area managers, lab technicians, and Swasthya Sevika, who are the frontline community volunteers in Bangladesh. So they identify they potentially identify the suspected cases, and they bring them for sputum collection either in the mobile sputum collection camps, or in the dot center, right? So after the sputum is done, if the sputum is positive, that child is enrolled in the tuberculosis program and started on DOTS therapy. But if the sputum is negative, they are referred to pediatrician or other doctors who then evaluate the child. And if they suggest that TB treatment should be established, then they are enrolled in the TB program and TB treatment is started. One good thing about TB treatment in Bangladesh is that the patients need to take their treatment from the nearest Swasthya Sevika's house. They need to go to their house every morning to take their medicine. And it is being monitored by the program organizers, program officers in the field. And if they fail to present in Swasthya Sevika's house in the morning, the Swasthya Sevikas used to go to their house in the afternoon to ask why they didn't show up in the morning. So in this way, they are intensively monitoring the program, the treatment, so that the treatment, the DOTS treatment is to some extent successful in Bangladesh. So what is the gap in the diagnosis? So let's see, delays in diagnosis. So we had interviewed 4 parents of TB patients who were currently undertaking a TB treatment. So the way the TB patients were identified by the doctors was challenging right now. So if we see the pathway of diagnosis, only one child was diagnosed within 1 month of having the symptom, but that also because he had seizure, right? So when he had seizure, he was directly taken to a tertiary care hospital, the Dhaka Medical College Hospital, where he was undergone a lot of diagnoses for 3 weeks, and then he was started TB treatment as tubercular meningitis when other diagnoses were failed, right? So that child who presented with one of the most severe symptoms was identified earlier within 3 weeks of presenting with the symptoms. But if we see the path of diagnosis for the rest of the cases, so these rest of the patients have been hovering around in between doctors, paramedics, traditional healers in the government as well as private hospital for a long time before they were eventually diagnosed with tuberculosis, right? And most of them told, one of the interesting story is that most of them told that they were started with TB treatment when they were not, when the doctors were not able to diagnose with other alternative diagnosis. So TB treatment was started as a trial basis, and when the symptoms got improved, the treatment was continued. Rather than as a definitive diagnosis, TB treatment was started as a provisional or preliminary diagnosis when other diagnoses were not explained by different investigations. So that is why there is a big delay in identifying childhood TB cases, so which is causing a big problem in the community, because tuberculosis is a highly communicable disease until the treatment is started, right? So when we start the treatment, tuberculosis is no longer a communicable disease, but unless and until treatment is started, it's a highly communicable disease. So when we cannot identify the childhood TB cases in the community in the earlier stage, there is a higher chances that these children are contributing to the rapid turnover and communication of the disease in the community. So although they are less likely to produce sputum, which is one of the most contagious form of tuberculosis transmission, however, they are still able to transmit the tuberculosis in the community, which is undiagnosed, right? So we also asked the frontline healthcare workers about their CAP knowledge, attitudes, and practices in tuberculosis diagnosis, treatment, as well as Isoniazid prevention therapy, right? So in the in the survey that we conducted, we interviewed 111 Swasthya Sevikas. We identified this number by a statistical power analysis. We had 80% power and 90% confidence of having at least 50% of the Swasthya Sevikas will have adequate knowledge in CAP. So with this provision, we calculated the sample size to be around 96. And with 20% non-response rate, so our sample size was 116. So out of those 116 that we interviewed, we had 111 complete responses, which we included in the data analysis. And one interesting fact was regarding the 3 cardinal symptoms of tuberculosis, most had correct response. Almost 3/4 of them had the correct response regarding the 3 cardinal symptoms of tuberculosis. That is, they were adequately identifying the suspected cases in the community from these 3 cardinal symptoms. However, one of the challenges in identifying children is that they are less likely to have all those cardinal symptoms of tuberculosis. That is why we are missing out a lot of cases, especially the extrapulmonary cases. For example, they were only about less than a third, less than 3/4 of them were telling that failure to weight gain is also a sign of tuberculosis. Similarly, we had throat pain, body ache, coughing. Those constitutional symptoms of tuberculosis were less identified by the frontline healthcare workers as one of the key symptoms of tuberculosis. So what we did during our qualitative analysis was we broke down these factors, facilitators and barriers according to the 3 pillars of NTV strategy, right? So the NTV strategy that is being implemented by the World Health Organization has 3 pillars. So 3 pillars, we organized our data analysis according to these 3 pillars: bold policies, workforce, as well as research in these 3 pillars. So what we found was there were few facilitators and there were few barriers for effective implementation. For example, one of the facilitators was provision of financial support for the patient during diagnosis. So when they are referring any patient for diagnosis, they were paying certain certain transportation cost, irrespective of the outcome of the investigations, right? So they were providing around 2,500 taka Bangladeshi rupees at that time, which was equivalent to around $30, right? $30 in our context is a big amount, especially when we are suffering from poverty, when we have no adequate money when we have a lot of out-of-pocket expenses for healthcare. It's a big amount of money for the people. So the BRAC is providing some referral cost for the people while they are going through the diagnosis for tuberculosis. And this money is provided irrespective of the outcomes of the investigations, right? So the financial support was one of the factors that was contributing for the diagnosis and treatment. Similarly, as I mentioned earlier, there was regular monitoring and supervision of the suspected cases before and after diagnosis during treatment. So which was one of the key facilitators for effective diagnosis and treatment. So the Swasthya Sevikas and other frontline healthcare workers were getting regular training as well as refreshers for their knowledge improvement, knowledge enhancement, which was one of the good facilitators, and good knowledge on the cardinal symptoms of tuberculosis. So as they had good knowledge on cardinal symptoms, they were identifying a lot of cases in the community and referring them for sputum as well as other investigations. And similarly, regular supply of drugs was identified as one of the facilitators. Similarly, we had a lot of barriers as well. So one of the key barriers being the stigma, right? So stigma was playing a big role in the community. So people were not coming forward to think that their children might have tuberculosis, and they were not willing to investigate for the kids. Right. So there was lack of adequate training on childhood tuberculosis, especially to the medical officers in the rural areas, especially for the medical officers in the primary healthcare centers, which is called as Upajilla Health Complex in Bangladesh, as well as lack of diagnostic facilities. As we discussed earlier, the the presence of gene expert was limited to the cities, and when we see the trends, we could see that the number of cases was highest in the Dhaka region compared to the other regions in Bangladesh. So the inadequate distribution of diagnostic tools in the different parts of the country was one of the key barriers, as well as lack of IEC materials in childhood tuberculosis was identified as a key barrier. So bold policies and supportive systems, which is the second pillar. So they were telling, it was identified that the presence of national guidelines, training and capacity building of pediatricians, as well as government ownership of the program was leading to the increasing number of cases. However, shortage of the health workers was identified as one of the key barriers, especially the medical officers, the doctors at Upajilla Health Complex and the government facilities. The absenteeism as well as lack of posting of adequate number of doctors was identified as the key barriers. Similarly, being a government program, there was rapid turnover of the key managerial people. So people were finding difficult to coordinate with the government to implement policies, to implement research activities for tuberculosis program. Similarly, one of the factors that was identified as a barrier was the lack of research activities among the for childhood tuberculosis. So Bangladesh, if we see in the context of tuberculosis control and management, if we see the context of MDR-TB. So previously, if we remember, the treatment of tuberculosis MDR-TB was around 24 months. Because of findings from a research in Bangladesh, the treatment duration of MDR tuberculosis was reduced to 9 months. So Bangladesh has done many innovative research in tuberculosis management, tuberculosis control. However, Bangladesh is very far behind in the research for childhood tuberculosis, probably because of the fact that there was limited resources, limited finances available in childhood tuberculosis. And what we identified during our research was the government was blaming towards the implementing partners, whereas the implementing partners were blaming back to the government that they should lead the research and innovation on childhood tuberculosis. And due to this tussle between the government and the implementing partners, there were very less research activities for childhood tuberculosis. So this is one of the participant telling participant from the National Tuberculosis Program who was telling that diagnosis of tuberculosis in rural areas is tough as FNAC is not done in the rural areas. So it is not done in all of the district hospitals. Only few of them offer this test. Usually it's done at the tertiary hospitals like medical colleges and private pathological laboratories, but these are very less in number in the remote districts as well as in the rural areas. So due to this lack of adequate infrastructure, there was very few diagnosed tuberculosis cases in children in the rural areas. And then we had some supply chain management issues as well. A minute, please. So the main thing is that the Swasthya Sevikas are the frontline health workers who are providing their services free of cost to the government. So they are volunteers and they are engaged not only in the tuberculosis control program, but in the other activities as well. So they are overwhelmed with their responsibilities, although they are trying to drag the tuberculosis control program as one of their integral components of their job responsibilities, but it is very hard for them. However, their work is still recognized and acknowledged by the government as well as the implementation partners. And some of the implementation partners and the program organizer were telling that the biggest role is theirs. They live in the community, and they can closely monitor the patients as well as the clients, and people respect them. So whenever a Swasthya Sevika tells people to go for a testing, people usually acknowledge their words, and then they go for the mobile camps to give their sputum. But the challenge with childhood tuberculosis is that very less children are able to produce sputum, and it is difficult for the healthcare professionals to collect sputum in other ways, like gastric lavage, in which they will give saline to the child and then collect the sputum from the stomach using a nasogastric tube. So there are challenges in identifying how to collect the sputum, as well as producing sputum in children, which is one of the most traditional way for diagnosing tuberculosis. So they are overwhelmed with workload. So that is why some of the people were also telling that sometimes I feel like quitting my job, as I have to do office work even in the weekends. So and then one of the Swasthya Sevika was telling that they are not working in a salary system, so it's a voluntary work. And for a completed treatment, they were usually given 500 as reimbursement for their work, so compensation to their work, but that amount is not sufficient for motivating them to work in the community. So there were a few HR issues as well. So I would not like to go to the individual statements, but the thing was basically the key managerial positions were rapidly turnover. So there was rapid turnover of key managerial positions. So it was difficult for the implementing partners to negotiate with the government, as well as in the field level, there was absenteeism of the medical officers as well as pediatricians who do not want to go to the rural areas because they do not have enough earnings, and the salary given by the government is not sufficient. So pediatricians usually will not tend to stay in those areas, rural areas, for a long time. Even if they are posted over there, they will just go there, have their attendance done, and then come back to the cities for a better job. So they hardly stay there for over a month. So that is why those posts are almost vacant throughout the year. And the medical officers, who are the frontline doctors in the rural areas, are not provided with adequate training on childhood tuberculosis. So they were telling that they had not heard of childhood tuberculosis implementation program. They had not heard of any training on childhood tuberculosis. So it was very hard for them to focus on childhood tuberculosis. And also one of the key managerial implementing partners, the national program officer in the government national tuberculosis program, he was telling that childhood tuberculosis is a diagnosis of exclusion, not a diagnosis of inclusion. So whenever people are not able to provide any bold diagnosis on a child, they will label them as child with tuberculosis and give a trial of anti-tuberculosis drugs. So these are few key challenges with tuberculosis in the thing. Similar is the implementation pathway of the isoniazid prevention therapy. So almost the basic concept of isoniazid prevention therapy is that if any member in a family is diagnosed with tuberculosis, then in that family, if they have a child who is less than 5 years of age, then they are provided with isoniazid prevention therapy for 6 months. So this is how isoniazid prevention therapy is delivered in Bangladesh. So it is also provided by the Swasthya Sevikas under their direct observation. So to all children under 5 years of age who are living or exposed to a case of tuberculosis. So in this way, the isoniazid prevention therapy is being implemented in Bangladesh, but the most of the facilitators and barriers for this IPT was also similar to those for diagnosis and treatment. So similarly, these are the facilitators and barriers which are similar to those of diagnosis and treatment. So I think there is a query in the chat rooms which I want to address at this point about the idea of reimbursement and incentives. You have seen that in that way, have you assessed its negative impact, especially on the level of belongingness among health workers towards working in TV units tasks? Thank you. So maybe probably we did not address to your query specifically because our target was to identify the facilitators and barriers, although it's one of the key component that we should have addressed, but we hadn't addressed it during our research. So probably, yes, incentives and reimbursement is one of the key facilitators for people to go for diagnosis and treatment. Regarding reimbursement, we had investigated to some extent. What we found was that they were providing reimbursement, which was a positive thing, but to get that reimbursement, there was a mandatory step. That mandatory step was the child has to have a sputum test, and that sputum test has to come negative, right? But the challenge with childhood tuberculosis is that very few child can produce sputum, especially those below 7 years of age. So that was one of the challenges regarding the reimbursement. So they were telling, even the program managers were telling that most of the people who were getting the reimbursement were the adults rather than the children, because they were able to produce sputum, and when their sputum was negative and they were referred for further investigations, they will get that reimbursement for payment to those investigations relating to tuberculosis diagnosis, right? So, but those who were not able to produce sputum, not able to undergo a sputum examination, were not eligible to get that reimbursement. So that was one challenge regarding the reimbursement. Although it was good, but the challenge was most of the children who were under 5 or under 7 years of age were not getting reimbursement because they were not able to produce sputum for investigation. Similarly, and one of the other thing that the people, the field level implementers had identified was folk songs, theaters, plays were one of the good ways to communicate or create awareness among the people. But during the time of our research, there were very less funding on these sort of activities, which was helping to create awareness in the people. So they were demanding that these sort of activities should be given priority. But on the other hand, when we talked with the key implementers, they were telling that they had very less funding for research activities. They had very less funding on awareness activities, and they were telling that the implementing partners should organize funds by themselves for these sort of activities. So there was a tussle between the government as well as the implementing partners on who should invest on these awareness activities, who should invest on these research activities. So that was a key challenge over there. And then a good thing was they were telling that there was no shortage of tuberculosis drugs for the past 5 years. That was a good thing in the implementation of this program. So as there is adequate stock of the drugs, so we can people can be ensured that they are getting treatment on a regular basis without any interruptions. So thank you, ABB, for sharing your information. We would love to hear from you in the next webinars regarding your research, so that we can share with each other. We can plan what we can do in collaboration for improving research on the tropical diseases, right? So we look forward to hear from you on your research and your findings. So in discussion, so I briefly presented the rationale behind our study and how we conducted the study and what were the findings, right? So the thing is, in Bangladesh, the prevalence of childhood tuberculosis is lower compared to other high burden countries. So whatever tuberculosis trend that we reviewed in Bangladesh was below 5%, and it was similar to Indonesia and other countries with high burden of tuberculosis. So there is a big gap and big challenge on how to improve the number of cases of childhood tuberculosis. So this is a gap where we can collaborate on. So we can have a partnership to do one trend study of those 30 high burden tuberculosis countries to see what is the trend of childhood tuberculosis diagnosis in these 30 countries, and we can have a good paper out of it. So if we can coordinate it with different universities and across the different TDR scholars, it would be a good idea and good contribution to research. So the children in the 0 to 4 age group are often left undiagnosed or unreported because it is very difficult for diagnosis of tuberculosis in this age group because of many reasons, like they are not able to produce the sputum for examination. Also, they do not produce the typical cardinal symptoms of tuberculosis, and as they are presenting with different types of symptoms, they are not investigated in the line of tuberculosis from the very beginning. So tuberculosis is considered as a diagnosis of exclusion rather than the diagnosis of inclusion in different areas and different communities. So the national guideline is a good way to have a tailored management program. However, there needs to be modifications to incorporate how to diagnose and treat tuberculosis in children. So also what we identified was that the World Health Organization has recommended a liquid form of tuberculosis treatment for children, which was not yet implemented in Bangladesh, right? So we had, if we remember, we have 4 FDR combination for tuberculosis treatment, right? So 4 drugs in a single tablet. So this tablet form with 4 drugs, the 4 drugs is also available as a syrup form, but that has not been implemented in most of the high burden countries. So they are still depending on the tablet, which is difficult to be fed to the children. So the mothers were telling that it is very hard for us to provide tablet to the kids, and we sometimes we cannot tolerate the child taking the tablet, not only the child, but the mothers also cannot tolerate when they see the child vomiting after getting the medicine. So vomiting continuously after getting the medicine, the mothers cannot even tolerate it, and they think that, oh, I don't want to give medicines for my child for such a long time. So there are a few gaps in addressing those issues in Bangladesh. Also, the lack of gene expert, social support from the private sectors was also contributing to the effective implementation of childhood tuberculosis. So also the political commitment is required and was highlighted by the participants. Gap in IEC materials was highlighted by the participants, which was consistent with the previous research for childhood tuberculosis. So effective DOTS coverage. So DOTS was very effective in Bangladesh, which was one of the reasons for successful treatment completion and less failure rates. And also, as I discussed earlier, lack of leadership and the rapid turnover of key managerial positions was also associated with tuberculosis implementation. So there are other programs like improving IPT uptake was highlighted by the participants, and counseling was not adequate or ill-equipped because they had less IC materials for childhood tuberculosis. Even we had visually observed that. So when we visited those 8 DOT centers, only 2 of them had IC materials on childhood tuberculosis. The rest, 6 of those 8, that means 3 out of 4 DOT centers did not had any IC material for childhood tuberculosis, which is a big gap in implementing childhood tuberculosis. So conclusion, Bangladesh has been able to detect and treat more childhood tuberculosis in the past few years due to capacity building, technological advances, and other provisions. However, it is not up to mark because up to mark is said for 10 to 15% of incidence being from childhood tuberculosis group, but the incidence reported from this age group is less than 5% till 2021. So the horizon of active case detection needs to be expanded to reduce the burden of the disease. And increasing awareness among people is the biggest challenges. So this is all from my side. So I now open the floor for any discussions or comments or any other feedback. As Avivi has mentioned, I request him to coordinate with Nidhi to organize. I request Nidhi to coordinate with you to organize another webinar on your work so that we all can be benefited from each other's work and we can develop partnerships among us for future collaboration. Dendu, do you like to add anything on what we have discussed till now?
Thank you, sir. Thank you so much, Sandesh bhai. I think I have nothing to add because whatever you have explained, I think that should be okay. And I think basically, just to give a thought, maybe like if some of our colleagues or the participants here attending are working for tuberculosis program, they would also know that the problem or the challenges faced by the national program managers or program officers would be similar in everywhere, because especially with regard to diagnosis of tuberculosis among the children. Case in point, like in Bhutan, the WHO says, yes, according to WHO, Bhutan is considered as a low-burden tuberculosis country. And for the low-burden country, the proportion of TB cases among the overall TB should be around less than 5 to 10% or less than 10%. That's acceptable. But then, if you look at our figures, it has been around 3%, 2%. So I think the challenges is still there. So I just want to give the thought on that. If any of our participants are working for tuberculosis, we still need to do a lot. I think that is the biggest challenge, because said and done, whatever said and done, the reasons my colleague Sandesh has already mentioned. So nothing like that. We need to work on the upscaling the diagnosis among the children. Unlike, because the one reason could be like the children are not able to express what is their difficulties. The other reason is, yes, Sandesh Bhai was mentioning, like my colleague was mentioning that it's a kind of even the medical officers are saying like, okay, let me try if it could be a tuberculosis. So there are a lot of challenges. So I think we need to improve. So I just want to give this information, but like Bangladesh and some other countries, we have about 30 countries that contributes almost 70 to 80% of the tuberculosis globally. So for them, the proportion among tuberculosis among the children should be around 10 to 15%, but it's way below. So anyway, there are a lot of challenges. I just want to say this. Thank you so much, Sandesh, for having the wonderful presentation on behalf of the colleagues. Thank you so much.
Yeah, so anyone who would like to have any feedback or comment or queries, please share. So what in our last webinar, our colleagues from Indonesia, they had shared their research on tuberculosis. So we are doing a lot of activities on childhood in tuberculosis, especially as a part of our TDR program. So let us, it would be good idea if we could synthesize our results and then probably work on the gaps and challenges to provide a better solution to those challenges, as mentioned, as also highlighted by Dendu. So the gap between what is recommended by WHO and what is found in the field is very big, and we need to work to reduce. How can we reduce this gap, right? So one of the ways is to identify the potential challenges and potential gaps, and identifying strategies on how to improve those key loopholes. So let us work for, we can collaborate together. So to identify few things, conduct few research, and then we can help program managers, implementers to find a solution to those gaps and challenges that we can identify from conducting some research in, especially in tuberculosis and leprosy in our part of the world.
Hello.
Hello, yes, please. How are you?
I'm good, and how are you?
I'm good, thank you.
Thank you for the comprehensive presentation. I joined in a bit late, but I followed through to the end. What I wanted to hear from you was what was the topic and how far have we gone in terms of implementation-wise? Who are the major stakeholders? I've heard the challenges and the enablers that you presented, but the point that I missed was how far are we in terms of implementation-wise? Have we started, or are we planning to start anytime sooner, or we are planning that other countries should join in? So if you can help me with those, I think that would be.
Thank you,
Thank you.
Beatrice. Thank you, Beatrice. So regarding the implementation, so we studied the implementation pathway of existing implementation of tuberculosis pathway in Bangladesh to identify the facilitators and barriers, right? So we discussed the bottlenecks in implementation, and we identified whatever we had identified, we presented it to the WHO representatives as well as to the BRAC representatives during our graduation ceremony. After a graduation ceremony, we had a meeting with them. So we presented our results with them, and we are currently we have submitted this manuscript and is under peer review. So if accepted for publication, then we will share it with the other organizations as well as with the different tuberculosis implementing partners in Bangladesh to review their policies and to improve on the implementation strategies based on the recommendations provided by this study. So, and another query, your query was what was the research topic? So our research topic was investigating the facilitators and barriers to implementation of childhood tuberculosis in Bangladesh.
Okay, thank you so much. I asked that because I'm from University of Zambia under the scholarship, WHO-TDR scholarship, yes. And we are our first months, and we're in the process of developing our problem statements and developing our proposals. So when you came up with the idea of collaborating, so I thought maybe this could be another opportunity for some of us who might have interest.
Definitely. Yeah, definitely.
Yeah.
It could be. You could. What we can do is we had a previous session by our University Gaza in Indonesia that colleagues had shared their experiences from tuberculosis research. So we had now shared our experiences from tuberculosis research. So you can select or identify topic that has not been yet addressed for tuberculosis research. One of them could be, which I was keenly interested at that time, was the reproductive health of tuberculosis patients. So, for example, most of the adult tuberculosis patients from the reproductive age group, they might have their own desires on reproductive health, right? So some of them might want to have kids, or some of them have other reproductive health needs and sexual health needs. But due to tuberculosis, they may have to be in isolation for a long time. They may have to be remain in isolation. So what are their challenges and what are their perspectives on reproductive health? That could be one of the good areas where we could explore, especially those with MDR-TB or XDR-TB. It could be a big problem for them.
Thank you so much.
Yeah, Jeffrey. So.
Hello, thank you very much for your presentation. I don't know if you can hear me.
Yeah, we can hear you, Jeffrey.
Yeah, I wanted to just ask, there's a point you talked about on some of the barriers. You talked about lack of leadership and policy. Would you just maybe explain to me that a little bit further? I was a little bit confused with the word lack of policy.
Okay, so
of leadership. I don't know.
Yeah.
Okay.
Thank you very much. So that was regarding the rapid turnover of key managerial positions in the National Tuberculosis Program. So because the National Tuberculosis Program was operated by the Ministry of Health and Population in Bangladesh, so what was happening in the program was the key managerial positions like the National Program Officer or the director of that program was being changed every 2 to 3 months, right? And while with the rapid turnover of the key managerial positions, it was hard for the implementing partners to be addressing their needs for implementation. For example, you go with one of your proposal today, and the very next day when you go with a follow-up on that proposal, the director would have been changed, right? And then you have to again start from the very beginning, right? And it was hard to convince each and every person in the forum, right? So you had hardly convinced one people to implement one thing, and the very next month that people is no longer over there. So, and the person who comes to replace that person is rejecting your proposal on that particular implementation. So this was one of the biggest challenges that the key implementing partners were facing in Bangladesh. So that is why we call it lack of effective leadership in implementing childhood tuberculosis. Would you like to add something on this?
Not necessarily on the lack. I mean, the lack of leaders. I just want to, give my thought or idea, like if Mrs. British might like it, if she's willing to. The one area we could look into is study tuberculosis among health workers. That could be one, because we can see, I think it should be the situation is similar in other countries as well. In Bhutan, we see quite a good number of health workers getting infected, and if we narrow down, maybe you can look at the health professionals, health workers who are working with the TB ward or TB unit, tuberculosis unit, or otherwise also maybe you can choose the dental section is one area that the people we see getting infected with the tuberculosis. So that's the one that I wanted to suggest if British would like to be interested on that. Thank you.
There are a lot of unexplored areas in tuberculosis research which we need to explore on.
Thank you so much. I think the response is overwhelming. I'll be able to give out my response through the email that was sent.
Yeah.
So do you have any more questions?
Excuse me. I'm interested to know the fatality rate of the TB among children.
So probably we didn't, thank you for your question, but I am not able to answer your particular query because we didn't look at this particular outcome. We were just interested in the prevalence of tuberculosis in children, incidence and prevalence. So we did not look after the case fatality rate. And also that is less, and the basis of our trends analysis was the data from the BAC tuberculosis program and the National Tuberculosis Program. I think we didn't extract the data on the case fatality rate. So we just had the number of new cases and prevalence cases only. So we just had the prevalence data based on gender, based on age distribution, and then geographical distribution, but we didn't collect any other additional data.
Thank you, sir. Followed by involving community volunteers like Shasta Shavika in TB care management. Since TB is a highly infectious disease, and involving these untrained and unprofessionalized community volunteers, which they need to engage throughout the treatment course, like it may take for 6 months to 1 year and even more. So is there any risks that the risks involved for that professional that volunteers, And have you seen any of the participants that they have been reported with the TB cases being involved as a volunteer for TB management?
Thank you, Sherin. So we didn't particularly ask the Swasthya Sevikas if they had ever been infected with tuberculosis. And as Dendup suggested, this is one of the key areas that we need to explore, tuberculosis among healthcare workers. As we are closely engaged with diagnosis and treatment, there is a higher chance that we are getting tuberculosis, not only the normal TB, but MDR TB as well as HCR TB. There is a high chances that we are exposed, potentially at risk of exposure to these TB cases. So it's a good idea that we explore the trends and the prevalence of tuberculosis among the healthcare workers as suggested by Dendup. I think it is a good topic for future exploration. We have few colleagues who are undertaking their master's degree at this moment. So probably it would be a good opportunity for them to explore it during their dissertation.
Thank you, sir. Thank you. If there is any other questions, otherwise I would love to ask a few more questions. Let me give a chance to others.
Yeah,
Shall I
please.
ask one more question?
Yes, please.
Okay, sir, again, since you are now working in a TB program with the Minister of Health, I being the health worker here in Gelpo Hospital, now after COVID pandemic introduced globally and especially which the noise of COVID picked up too much in our country, no? So including TB, many of the important programs are almost being forgotten or missed out. So maybe internally your program must be battling a lot, but we don't hear any of the program officials or the people, those like health officials, those who are working at the field are not talking much about the TB. See, like in my hospital, TB unit was relocated somewhere else, and the number of cases has been reduced. Like normally, like MDR cases were separated somewhere else, isolated in a different unit, and like normal TB cases were managed in such a way. But after COVID hit our locality, then and the importance towards the TB program was, I think, almost neglected. So what was the challenge you faced? Maybe I think you are on constant touch with your field workers, but no, like even I asked this question with the Prime Minister and the Health Minister, but they are least bothered. And I have raised the multiple questions that no, uh, due to COVID, I think that the number of the death is very minimal, and the case fatality rate is also quite low. But many patients are dying with the different cases like TB and other. Because I have not seen any of the data, the cases, the death cases amongst TB patients. But it was my assumption that no patients could have died due to TB and other like infectious diseases as well as non-communicable diseases. But many our top policy makers are not talking much about no, the like dangerous disease like the TB. So I'm very interested to hear from you the challenges you faced and the way forward that you are looking for management of the TB.
Thank you so much, Mr. Penjor. I think it's from here, even the other countries, other colleagues here can maybe able to, if it sounds good, they can take as a lesson. I think I personally feel that COVID, indeed, maybe the paper may say different, but I personally feel that, in fact, this COVID in the last 2 years have helped us in reducing the number of tuberculosis. Why I'm saying so is that if you look at the figures overall in the last 3 years, just to give you the figures, in 2019, I think we have a little more than 1,000 national data, and in 2020 we had little more than 1,000. I mean, little more than, not even 1,000. I mean, it's 916, and for 2021 we have around 860 something, so or 825 something. So that, I mean, the number of reduction could be, I'm believing that this could be the positive impact of COVID, because the people were asked to wear masks. So, I mean, the transmission bit has, there is a barrier in transmission once TB patients are been asked to wear masks, and particularly in the last 2 years, not only the tuberculosis patients, but the whole population in the nation we are asked to wear masks. So I think that the transmission would have interrupted. So that is my belief that, but it's yet to confirm by the studies. But in otherwise, the WHO or other papers may say there is a lot of decline in studies. There could be a lot of challenges faced by the tuberculosis, not only tuberculosis, but the whole health system in the country. But as I said, personally, I would like to believe that it's a positive impact for the tuberculosis. And in terms of, just to mention one or two, it's not that the government is not doing anything. In first place, the major chunk of the fund is supported by the global fund. We still get the support from the global fund. New cycle has just begun since 1st July 2021. So from the point of the government support, initially, if I talk, basically in terms of support from the RGOB is like training the health workers, revising the guidelines, printing and making advocacy, the monitoring, supervision, all these are supported by the RGOB. But in the since last 2 fiscal years, I think we had a lot of support from the royal government of Bhutan. The major shift is now we have, I think we are getting enough fund for procuring the gene expert, and we have increased the number of gene experts in the country. In 2016, we just started with 2016 with 4 gene experts. And if you look at in terms of population and in terms of size of the area of our country, the people would say like 2 gene experts is enough for the whole Bhutan. But we are proud to say that we have at least 10 places, the gene expert in 10 strategic locations. So that's one area. And in terms of monitoring and supervision, particularly, yes, all of us would agree that we had a lot of challenges in monitoring and supervision. But we did not remain idle during especially lockdown time, and also during this COVID period. Rather, we have improved our monitoring system by creating the group chats in WhatsApp, and we also are the social media like WeChat group is also popular. So not only with creating the WeChat group, we also try to have the group with the tuberculosis patients so that our TB in charges are being able to monitor when they are not able to physically visit and monitor them. And we had made sure that no interruption of the tuberculosis medicine, not only in terms of non-lockdown period, but even in the lockdown period, because during the lockdown period, although the other people, general people are not allowed, but the health professionals, health workers, based on the needs. So I think we made it clear that we have done our job, and we will continue to do so if the COVID situation still remains or become worse. But as of now, we are proud to say that now it's improving. The situation is improving. I don't know if I have captured all this. And in terms of training, now in terms of training the health workers, wherever possible, we try to conduct the physical in-person training. But when the situation did not allow, or when it's not feasible to call all, particularly the Bhutan had considered, we met for the COVID, we met the high risk and low risk. So for our health workers, particularly the TB in charges and medical officers, then people who are other people who are clinicians, who were involved in diagnosis and management of chains of supply chains. So we try our best, and I think this will continue. And this is one area that we need to continue, like giving the virtual training, conducting the virtual conferences, meetings, and seminars. I think this is an opportunity that we have to leverage the modern technology, IT technology. So I don't know if I have to respond to your question, Mr. Sering.
Yes, you have given a comprehensive response beyond my doubt. I'm very much grateful, sir. Thank you. So I'm a bit relieved. Otherwise, no, I was almost in the doubt and suspicion, no? Thinking that our patients must be dying without receiving proper attention from the health workers. Thank you, sir. Thank you.
Thank you.
Is it like the tussle between the implementation and field level health workers in Bhutan as well, like in Bangladesh? So the way implementers are telling is different in the field.
So, and Sandesh, we have a request. So we have a request from Ririn to share your PPT. So is that possible?
Okay, so I can send an email to you, and then you can share to those who have participated. I will do it tomorrow.
Yeah, thank you. Thank you, Sandesh. So I'll get back to Abibi later.
Okay, yes, sure.
And hopefully we can have one more session.
Another webinar from
Yes.
OBB. So we need to continue this webinar. So anyone who would like to share their research and their findings we are more than happy to welcome as a chair of this steering committee. I'm happy to welcome you all who want to present and share our own research. Maybe Siring can also share his experience, and then we have few colleagues from BRAC who have recently passed out, so they can also share, like Ririn, And then Subhagya was there. I think she has left already. So you guys also can share your findings, your research, so that we can help each other. And as Beatrice is here, she could get some insights regarding her future research. So it's helpful to everyone.
Yeah. So I'm sharing the IR Connect email in the chat. So you can reach out to us for organizing webinar or talk or interviews or anything, or for any other further doubts. You can write to us at mail@irconnect.net. Also, we are sharing our website. So thank you everyone for joining our webinar. Thank you so much. So you please feel free to write to us in our mail. And thank you for joining. That's it from my end. Yes, Sandesh.
Bye-bye. See you again.
See you.
Bye.
Bye-bye.
Thank you.
Thank you.